Welcome, curious minds, to another deep dive. Today, we're plunging into a topic that's absolutely fundamental to understanding our bodies and the medicines that interact with them. The fascinating world of Cholinoceptor-Activating and Cholinesterase-Inhibiting drugs. To really set the stage for why this knowledge is so vital, let's start with a scenario right from our source material. Imagine 43-year-old JM, a vegetable picker, suddenly brought into the emergency department.
Oh, yeah, that kid.
He's agitated, unsteady, struggling to speak and swallow, with blurred vision and eyes tearing up. His coworker mentions a sulfur smell in the field they were working in, which had been sprayed that very morning.
Mm-hmm.
Within just 3 hours, JM was complaining of chest tightness and difficulty breathing before he became disoriented.
Yeah, this powerful case study immediately highlights the profound impact these compounds can have. It's a vivid and frankly pretty alarming example of just how critical it is for professionals and for anyone wanting to truly master this area of pharmacology to understand not just what these drugs do, but how they work at a molecular level and why their effects manifest as they do, sometimes with such devastating consequences.
Exactly. Our mission today is to go deep, very deep. We're going to uncover every concept, every detail about these cholinomimetic drugs. We'll trace their history, explore their intricate mechanisms, see their widespread effects on nearly every organ system.
Yeah, almost everywhere.
And understand their vital clinical applications, as well as their dark side in toxicology. You'll gain the kind of foundational understanding that allows elite professionals to truly master this space. Okay, let's unpack this. So where do we begin our deep dive into these fascinating compounds? With the star of the show itself, acetylcholine.
Acetylcholine, right.
Yeah.
This is the natural neurotransmitter that all of our target drugs either mimic or, amplify.
Okay.
What's truly interesting in our sources is how our understanding of these drugs actually preceded the full identification of acetylcholine. It's kind of backward.
Really? How so?
Well, early studies of the parasympathetic nervous system, the rest and digest part of your nervous system, noticed that a natural alkaloid called muscarine mimicked the effects of parasympathetic nerve activity.
Ah, okay.
So they call these effects ParaSympatho-Mimetic. And the sites where they occurred, like smooth muscle and glands, were simply named muscarinic receptors. It was a description of the effect, really, before we knew the underlying cause.
And then there was nicotine, which had a totally different set of effects.
Exactly. In low concentrations, it stimulated different sites, like the autonomic ganglia, the sort of relay stations for nerves, and the junctions where nerves meet skeletal muscles, but not those same muscarinic effector cells.
Got it. Different targets.
Precisely. Those specific sites were then labeled nicotinic receptors. It was only later, when acetylcholine was finally identified as the physiological transmitter for both these receptor types,
Ah, the missing link.
that we realized both muscarinic and nicotinic sites were just different subtypes of the same acetylcholine receptor. This historical perspective, it really helps us understand the dual nature of these drugs and how scientific understanding evolves step by step.
Now let's get into the nitty-gritty of these receptors. Our source describes two major families, the G protein-linked family and the ion channel family.
Indeed. Muscarinic receptors are members of that G protein-linked family. Think of them as tiny communication towers embedded in your cell membranes.
Okay.
When acetylcholine or a drug binds to them, they don't just sit there, they trigger a messenger system inside the cell, kind of like passing a note to the cell's internal machinery, telling it to react.
So an indirect effect, almost.
In a way, yes. Structurally, they're complex proteins with 7 segments that span the cell membrane, and their third cytoplasmic loop is coupled to G proteins. These G proteins act as transducers, translating the external signal into internal messages, regulating intracellular second messengers like calcium, and modulating ion channels. The specific effect depends on the particular muscarinic receptor subtype, M1, M2, etc., and the G proteins present in that cell.
So what are these subtypes and what do they actually do?
Our sources table 7.1 is key here because it simplifies the complexity. Without needing to memorize every single detail, the core insight is that these tiny differences allow our body and drugs to be incredibly precise, like having different keys for different locks.
Right.
So M1, M3, and M5 are generally, let's say, excitatory in terms of cellular response. They're linked to GQ11 proteins, which trigger a cascade that leads to increased intracellular calcium. M1 is prominent in nerves and involved in cognition.
Memory and learning.
Exactly. M3 is found in glands, smooth muscle, and endothelium, crucial for things like digestion and blood vessel dilation. M5 is less common, but also in the CNS.
Okay.
Then M2 and M4 are generally inhibitory. They're linked to geoproteins, which inhibit a messenger called CAMP and can open potassium channels. M2 is primarily found in the heart, nerves, and smooth muscle, basically slowing things down.
The brakes.
Right. And M4 is primarily in the CNS.
And these muscarinic receptors can even form dimers or oligomers, which sounds like they team up. That might play a role in how they move around or signal.
That's right, which is a fascinating nuance showing their dynamic nature. These receptors are integral proteins found not just in your central nervous system and the organs directly innervated by the parasympathetic system, but also in autonomic ganglia and even on the endothelial cells lining your blood vessels.
Oh, interesting.
And the sweat glands that are actually innervated by sympathetic nerves, surprisingly, that use acetylcholine. Their widespread presence truly underscores their systemic importance.
What about the nicotinic receptors? They sound quite different from the muscarinic ones.
They are very different. Nicotinic receptors are part of the ion channel family. Think of these as a gate that opens directly when activated, rather than triggering that internal messenger system.
More direct.
Much more direct. They are transmembrane polypeptides made up of 5 subunits, alpha, beta, gamma, delta, or epsilon, that literally form a channel selective for positive ions.
And where are these direct-gated channels located?
They're found in a few crucial places. The plasma membranes of postganglionic cells in all autonomic ganglia, which our source refers to as neuronal type, or NN.
Okay, the nerve relay stations.
Exactly. They're also on the muscles innervated by your somatic motor fibers, the ones that control voluntary movement, known as muscle type, or NM, right at the neuromuscular junction. And importantly, on some central nervous system neurons, too.
So if acetylcholine has such diffuse effects, activating all these different receptors everywhere, how do drugs manage to achieve selective action? It sounds like trying to hit a specific target in a crowded room.
That's a critically important question. And it's key to using these drugs therapeutically. The body does have multiple sites of action for acetylcholine, initiating both excitatory and inhibitory effects, sometimes simultaneously.
Right, it could be chaos.
It could be. Fortunately, drug selectivity is achieved by several factors. Some drugs are designed chemically to specifically stimulate either muscarinic or nicotinic receptors, ignoring the other.
Okay, molecular specificity.
Yes. And even within nicotinic receptors, different subunit combinations mean some agents can preferentially stimulate neuromuscular junctions over ganglia. Furthermore, a clever trick is using appropriate routes of administration.
Ah, like the eye drops you mentioned.
Exactly. Using topical eye drops for muscarinic stimulants allows for pharmacokinetic selectivity by minimizing systemic effects and keeping the drug concentrated exactly where you need it. This allows for incredibly targeted therapeutic interventions.
Let's transition from what these receptors are to how the drugs interact with them. Our source classifies cholinomimetics by their mechanism of action. Direct acting and indirect acting. This seems like a really fundamental distinction.
It truly is. Direct-acting cholinomimetic agents are straightforward. They simply bind to and directly activate either muscarinic or nicotinic receptors, just like acetylcholine itself would. They're like a key fitting directly into the lock.
Got it. They mimic acetylcholine.
Precisely.
And the indirect acting agents, how do they work their magic?
They work differently. They produce their effects by inhibiting acetylcholinesterase, or ACE.
The enzyme that breaks down acetylcholine.
Exactly. This enzyme's entire job is to rapidly hydrolyze or break down acetylcholine into choline and acetic acid. Think of it as a molecular cleanup crew for acetylcholine, clearing the signal very quickly. By blocking this breakdown, indirect-acting drugs allow the body's own acetylcholine to stick around longer in synaptic clefts and neuroeffector junctions. The excess acetylcholine then stimulates cholineceptors more intensely, amplifying the physiological response. They're essentially amplifiers of the body's own chemical messenger.
I also noticed a mention of butyrylcholinesterase or pseudocholinesterase. What role does that play, and is it as important as acetylcholinesterase?
That's a good point. What's fascinating here is that while some cholinesterase inhibitors do also inhibit butyrylcholinesterase, this enzyme actually plays a minimal role in the physiological termination of synaptic acetylcholine action.
So it's not the main cleanup crew?
Not really for acetylcholine at the synapse. Its primary function seems to be more like a biological scavenger, maybe helping to mop up certain toxins or perhaps protecting AE from inhibition by things like organophosphates. However, our source points out a critical clinical relevance. A specific mutation in the BCHE gene can lead to a deficient butyrylcholinesterase. This means a person with this mutation might be unable to properly break down certain muscle relaxants and anesthetics used in surgery, like acetylcholine.
Oh, wow. So that could lead to problems.
Big problems. Severe, prolonged reactions like paralysis and apnea, inability to breathe. This really highlights the importance of genetic predispositions in how individuals respond to drugs.
And some of these indirect drugs can even have a dual action, right? It sounds like they're pulling double duty.
Yes, exactly. Some quaternary cholinesterase inhibitors, like neostigmine, have a modest direct action as well. In addition to blocking cholinesterase, they can also directly activate neuromuscular nicotinic cholineceptors.
So they amplify and mimic just a little bit.
Just a bit, at that specific site. This dual mechanism definitely contributes to their powerful therapeutic efficacy, especially in conditions like myasthenia gravis.
Now let's drill down into the basic pharmacology of these direct-acting stimulants. Chemically, they fall into two main categories based on their structure.
Right. We have the esters of choline, which include acetylcholine itself, methylcholine, carbachol, and bethanyl. These all share a common structural feature, a permanently charged quaternary ammonium group.
Charged? Okay. What does that mean functionally?
It means they're hydrophilic, they like water, so they're poorly absorbed when taken orally, and they don't easily cross into the central nervous system because of the blood-brain barrier.
So if they're poorly absorbed and can't easily get into the brain, how are they given clinically to be effective? Seems limiting.
That's a great point. They're much less active orally and often require parenteral administration, meaning injections, or a topical application like eye drops. Acetylcholine itself is very rapidly hydrolyzed by enzymes in the body, so intravenous effects last only a fleeting 5-20 seconds.
Wow, that's fast.
Incredibly fast. Methylcholine is more resistant to breakdown, and carbachol and bethanyl are even more resistant, giving them significantly longer durations of action. And an interesting detail from our source is that the bupmethyl group in methylcholine and bethanyl actually reduces their potency at nicotinic receptors,
Selectivity again.
while beautifully maintaining their muscarinic activity. This structural modification is key to their selective therapeutic uses, allowing them to target specific systems without widespread nicotinic side effects.
And what about the other category of direct-acting stimulants?
Those are the alkaloids, a diverse group that includes pilocarpine, nicotine, and lobeline. These are typically tertiary natural compounds and are generally well absorbed from most administration sites.
So these get into the body more easily.
Generally, yes. Take nicotine, for example. Being a liquid and highly lipid soluble, it can even be absorbed directly across the skin, which is why nicotine patches work.
Right.
Muscarine, another alkaloid, is a quaternary amine, so it's less completely absorbed orally, but it's still highly toxic if ingested, and can even enter the brain to some extent. These alkaloids are chiefly excreted by the kidneys, and a clinical tip from our source is that acidifying the urine can actually accelerate the clearance of the tertiary amines, which is useful in managing toxicity.
Let's connect this back to how they actually modify organ function. We've talked about the receptors, but how do muscarinic receptors signal to the cell to do something? What's happening on a cellular level? It sounds complicated.
This is where it gets really interesting and quite elegant, though, yes, a bit complex. When muscarinic receptors are activated, several intricate cellular events occur. Remember, all muscarinic receptors are G protein coupled.
Okay, the messengers.
Right. When M1, M3, and M5 receptors are activated, they trigger what's called the inositol trisphosphate, IP3, and diacylglycerol, DAG cascade. Think of this as a cellular alarm system.
Okay.
IP3 releases stored calcium from within the cell, and DAG activates other enzymes. This sudden influx of calcium is a powerful go signal for many cellular processes. Muscarinic agonists also increase cellular cGMP concentrations, another signaling molecule.
So multiple signals happening.
Yes. Furthermore, activation of muscarinic receptors can increase potassium flow out of cardiac cell membranes, primarily mediated by a specific G protein subunit binding directly to the channel,
Slowing the heart.
while paradoxically decreasing potassium flow in ganglion and smooth muscle cells, which can make them more excitable. And remember M2 and M4 receptors. They inhibit adenyl cyclase activity, which reduces concentrations of KMP, effectively attenuating the effects of stimulatory hormones like adrenaline or noradrenaline. These intricate signaling pathways explain the diverse and often opposing effects observed throughout the body.
So these tiny molecular changes inside the cell cascade into big, observable effects on our organs. What about nicotinic receptor activation? How does that work differently? Seems more direct.
It is much more direct. Nicotinic receptors have been studied in incredible detail, partly thanks to their high concentration in electric fish organs nature's little battery, and the tight binding of ibungerotoxin, a snake venom component, which serves as a molecular probe for isolation.
Wow.
The muscle nicotinic receptor is a pentamer, meaning it's made of 5 protein subunits. When an agonist like acetylcholine binds to its 2 specific sites on this pentamer, it causes a rapid conformational change that literally opens the channel.
The gate swings open.
Exactly. This allows rapid diffusion of positively charged sodium and potassium ions down their concentration gradients, sometimes even calcium ions, flowing directly into or out of the cell. This rush of positive ions causes depolarization of the nerve cell, or neuromuscular end plate membrane, leading to an action potential and ultimately contraction in skeletal muscle. It's a very fast direct electrical signaling system.
But there's a fascinating catch, isn't there? You mentioned that prolonged exposure to nicotinic agonists can actually stop the response, which seems counterintuitive. You'd think more stimulation means more effect.
This raises an important point about the nature of these receptors and how signals are normally terminated. Yes, prolonged agonist occupancy leads to what we call depolarizing blockade.
Depolarizing blockade, okay.
What happens is the initial rush of ions depolarizes the membrane, causing the initial contraction or firing. But if the agonist stays bound, the membrane can't repolarize properly to fire again. The voltage-gated sodium channels nearby enter an inactivated state. So the skeletal muscle relaxes because it can't sustain the contraction.
It gets stuck in the on state but can't reset.
Essentially, yes. Eventually, the receptor can even become desensitized and refractory to further agonist, even if the membrane partially repolarizes. This effect can actually be exploited in medicine, using drugs like acetylcholine to produce muscle paralysis during surgical procedures.
Okay, so we've got the molecular mechanisms down: direct binding, indirect amplification, G proteins, ion channels, even blockade. What does this all mean for the human body? Our source really dives into the organ system effects, and it's clear that knowing the physiology of the parasympathetic nervous system and where these receptors are distributed helps predict these outcomes. I'm thinking back to JM's symptoms and how these systems would be affected.
Absolutely. It all connects back. Let's go through the key systems that are profoundly affected by these drugs. First, the eye. Remember JM's blurred vision and tearing eyes?
Yeah.
Muscarinic agonists instilled into the eye cause miosis, that's pupil constriction, by contracting the iris sphincter muscle. They also cause accommodation or focusing for near vision by contracting the ciliary muscle. Both of these actions are primarily via M3 receptors.
Okay, so near vision focus and small pupils.
Right. And crucially, this ciliary muscle contraction also opens up the trabecular meshwork, facilitating aqueous humor outflow into the canal of Schlemm, which lowers intraocular pressure. This is incredibly beneficial in conditions like glaucoma.
The glaucoma connection.
Precisely. Next, the cardiovascular system. This is a complex area because of the interplay between direct effects and the body's reflex.
Right, the push and pull.
Intravenous acetylcholine directly causes vasodilation, meaning blood vessels widen, which reduces blood pressure. This is mainly an M3 effect on the endothelium.
Okay, lower pressure.
But the heart rate response is tricky. Lower doses might cause a reflex increase in heart rate as your body tries to compensate for the blood pressure drop. But larger doses directly produce bradycardia, a slow heart rate, and decrease conduction through the atrioventricular node, which controls the heart's rhythm, mostly via M2 receptors.
What are the specific direct cardiac actions that cause that slowing of the heart?
The direct cardiac actions, primarily via those M2 receptors, are multifaceted. They involve increasing a potassium current, which hyperpolarizes the cell, making it harder to fire. Think of it as making the off switch stronger.
Okay.
They also decrease a slow inward calcium current, which contributes to the force of contraction, and reduce a hyperpolarization-activated current involved in pacemaker activity. All of these effects contribute to slowing the pacemaker rate, leading to hyperpolarization, reducing the action potential duration, and decreasing contractility, especially in the atria. It essentially puts the brakes on the heart.
But you mentioned reflexes play a role too, so the body's response isn't always simple. It's a net effect.
Absolutely. The direct slowing of heart rate is often opposed by a reflex sympathetic discharge. Your fight-or-flight system kicks in due to the initial fall in blood pressure. This leads to a complex phenomenon called accentuated antagonism, where muscarinic modulation actually inhibits norepinephrine release from sympathetic nerves and affects postjunctional sympathetic cells directly.
Wow, okay.
Our source also highlights that muscarinic receptors on parasympathetic nerve terminals themselves allow acetylcholine to inhibit its own secretion, a feedback loop. So the net effect on heart rate is a dynamic interplay of direct actions in your body's counter-regulatory reflexes.
And what about the vasodilation you mentioned? How does that happen?
What's fascinating here, and really a key discovery, is that acetylcholine-induced vasodilation primarily requires intact endothelium, the inner lining of your blood vessels, and is mediated by M3 receptors on those endothelial cells.
Not the muscle cells directly.
Not primarily for dilation. These endothelial M3 receptors trigger the release of nitric oxide, or NO, which was initially identified as EDRF, endothelium-derived relaxing factor. NO diffuses to the underlying vascular smooth muscle and causes relaxation, widening the vessel.
Ah, NO is the messenger.
Exactly. Now here's a crucial point for understanding disease. If the endothelium is damaged, as it often is in conditions like atherosclerosis, acetylcholine can actually cause vasoconstriction via direct M3 activation on the smooth muscle cells themselves because the relaxing NO signal is lost.
That's a complete reversal.
It is. An interesting exception mentioned is pilocarpine. If given intravenously, it may produce hypertension after a brief initial hypotensive response. This seems to be due to sympathetic ganglionic discharge caused by activating M1 receptors on those ganglion cells.
Okay, let's move to the respiratory system. Remember JM's chest tightness and difficulty breathing. That sounds pretty direct.
Very direct. Muscarinic stimulants strongly contract bronchial smooth muscle, narrowing the airways, and stimulate increased secretion from tracheobronchial glands, producing more mucus. This is why these drugs can be problematic, even dangerous, for individuals with asthma or COPD, as it leads to severe bronchoconstriction. Our source highlights this as primarily an M3 receptor effect.
Makes sense. Okay, how about the gastrointestinal tract?
In the GI tract, muscarinic agonists significantly increase both secretory and motor activity. Think rest and digest turned up to 11. They stimulate salivary and gastric glands strongly.
Drooling and stomach acid.
Yes, and they increase peristalsis, the wave-like contractions that move food along while relaxing most sphincters, allowing things to pass through more easily.
Yeah.
M3 receptors are crucial for direct, smooth muscle contraction here, while M2 receptors might play a role in reducing the relaxing effects of sympathetic activity.
And the genitourinary tract. Similar effects.
Pretty similar, yes. They stimulate the detrusor muscle, which contracts the bladder wall, and relax the trigone and sphincter muscles at the bladder outlet, promoting urination. The M2 and M3 receptor functions here seem analogous to those in the intestine. Interestingly, the human uterus is not notably sensitive to muscarinic agonists.
Good to know. And regarding miscellaneous secretory glands.
Muscarinic agonists stimulate secretion from thermoregulatory sweat glands, the ones involved in cooling you down, which are oddly sympathetically innervated but use acetylcholine lacrimal glands, which produce tears.
Back to JM's tearing eyes.
Exactly. And nasopharyngeal glands, which produce nasal secretions. So, generalized increase in secretions.
Now let's dive into the central and peripheral nervous systems. These are complex control centers, so I imagine the effects here are profound and maybe less predictable.
They absolutely are profound and, yes, complex. The central nervous system contains both muscarinic and nicotinic receptors, with the brain being relatively richer in muscarinic sites and the spinal cord having more nicotinic sites. All 5 muscarinic subtypes are found in the CNS.
All 5. Wow.
M1 is crucial for cognition, things like memory and learning, and neuronal plasticity, which is how your brain adapts and forms new connections. Studies even show impaired plasticity in M1 knockout mice.
So vital for brain function.
Definitely. M2 seems involved in effects like tremor, hypothermia, and antinociception or pain relief. M3, especially in the hypothalamus, appears to affect appetite and body fat mass regulation.
Okay, so quite diverse roles for muscarinic receptors in the brain. What about nicotinic?
Despite fewer nicotinic receptors overall in the brain compared to muscarinic, nicotine-related agonists like lobeline has significant effects. Nicotinic receptors are found at both presynaptic and postsynaptic locations, meaning they regulate the release of various crucial neurotransmitters like glutamate, serotonin, GABA, dopamine, and norepinephrine.
So they're like modulators of other systems.
Very much so. The I4-2 oligomer, which is a specific combination of subunits, is the most abundant nicotinic receptor type in the brain. Think of it as the main highway for nicotine in your brain. It modulates hippocampal function, memory, and hypothalamic function, appetite, hormones, and is heavily implicated in nicotine addiction through its role in dopamine release in the mesolimbic reward system.
The addiction pathway.
Exactly. Chronic nicotine exposure leads to both activation and desensitization of these receptors, and that complex desensitization might actually contribute to the therapeutic benefit of nicotine replacement therapy by reducing withdrawal symptoms.
Interesting paradox.
It is. Now, high concentrations of nicotine can cause serious CNS effects like tremor, emesis, vomiting, respiratory stimulation, and even convulsions, potentially leading to fatal coma. This high toxicity is precisely why nicotine and related compounds like neonicotinoids are such effective insecticides.
Right.
Then there's the R7-AKHR subtype. This one seems important for cognition and pain perception, and researchers are developing positive allosteric modulators drugs that boost the receptor's function without directly activating it to potentially improve cognitive function in conditions like schizophrenia.
Fascinating potential there.
And interestingly, IS7-HEHR are also found on non-neuronal immune cells, suggesting they might have anti-inflammatory actions by reducing inflammatory cytokines, still an active area of research.
And for the peripheral nervous system, how do these drugs impact that network outside the brain and spinal cord?
Autonomic ganglia, those nerve relay stations, are key sites of nicotinic synaptic action, with the A3 subtype being primarily responsible for fast excitatory transmission. Nicotine affects both your parasympathetic and sympathetic ganglia similarly.
Both systems?
Yes, leading to an initial response that resembles simultaneous discharge of both systems. In the cardiovascular system, this often manifests as predominantly sympatho-mimetic effects like hypertension and tachycardia, but it can alternate with vagal effects like bradycardia. In the GI and urinary tracts, the effects are largely parasympatho-mimetic increased motility secretions. And remember that depolarizing blockade we discussed. Prolonged exposure to nicotinic agonists can also lead to that in the ganglia and at the neuromuscular junction.
Our source mentions a real-world and rather serious example of this, primary autoimmune autonomic failure.
That's a critically important clinical connection, yes. In some patients, their own immune system mistakenly produces autoantibodies that target the acetylcholine receptor subtype in the ganglia.
So the body attacks its own nerve relays.
Precisely. This causes severe autonomic dysfunction, leading to debilitating symptoms like orthostatic hypotension, a dramatic drop in blood pressure when standing up, and severe dry mouth, constipation, sexual dysfunction. The good news is that plasmapheresis, a procedure to remove these antibodies from the blood, can actually ameliorate these symptoms. Our source also notes that rare genetic deficiencies in these specific subunits can also cause widespread autonomic dysfunction, highlighting the fundamental role of these receptors.
Finally, the neuromuscular junction, where nerves connect to skeletal muscles.
Right. Nicotinic receptors at the neuromuscular end plate are similar, but not identical to those in autonomic ganglia. They are primarily the 1 and TQ1 types. When a nicotinic agonist is applied here, it causes immediate depolarization due to increased permeability to sodium and potassium ions, which leads to muscle contraction.
The trigger for movement.
Exactly. However, depolarizing nicotinic agents that aren't rapidly hydrolyzed by ACE, like acetylcholine or nicotine itself in high concentrations, can quickly cause that depolarizing blockade we talked about. This results in a concerning flaccid paralysis, illustrating the delicate balance of receptor activation required for proper muscle function.
Let's turn our attention now to the indirect acting cholinomimetics, the cholinesterase inhibitors. These drugs don't mimic acetylcholine directly, but they work by letting the body's own acetylcholine do more.
That's right. Their primary effect, their whole reason for being, is to inhibit acetylcholinesterase, thereby increasing endogenous acetylcholine concentrations at the synapse and junction. Their main differences are largely chemical and pharmacokinetic, how they're built and how the body handles them as their pharmacodynamic properties. What they do at the receptor level via acetylcholine are almost identical. They simply boost the amount of acetylcholine available.
Tell us about the chemical groups of these inhibitors. How do they differ?
There are three main groups, distinguished primarily by how they bind to the enzyme and, crucially, for how long that inhibition lasts. 1. Simple alcohols with a quaternary ammonium group, like edrophonium. These bind reversibly and briefly to the active site electrostatically and with hydrogen bonds, essentially getting in the way of acetylcholine. The enzyme inhibitor complex is very short-lived, lasting only 2–10 minutes.
Very short action.
Very short. Good for diagnostics. 2. Carbamate esters, like neostigmin and physostigmin. These actually undergo two-step hydrolysis, similar to how acetylcholine itself is broken down by the enzyme, but the bond formed with the enzyme, called a carbomoylated enzyme bond, is much more resistant to that second step, hydrolysis.
So it takes longer to break free?
Much longer. This leads to a prolonged inhibitory effect, typically lasting from 30 minutes to 6 hours.
3.
Finally, organophosphates, a very potent and often dangerous group, which includes the therapeutic drug ecothiopate, but also pesticides like parathion and malathion, and nerve gases like sarin and soman.
Nerve gases, wow.
Yes. These phosphorylate a specific serine residue in the active site of the enzyme, forming an extremely stable covalent bond. This bond hydrolyzes incredibly slowly, potentially over hundreds of hours. Furthermore, this bond can undergo a process called aging, where it chemically rearranges, which further strengthens it and makes it even harder, often impossible to break, even with reactivating drugs like pralidoxime.
So that's why they're called irreversible.
Exactly. Though molecularly, it's more about an extremely slow rate of reversal rather than absolute irreversibility. Functionally, it's often permanent for that enzyme molecule.
And their pharmacokinetics, meaning how the body absorbs, distributes, and eliminates them, does that vary much between these groups?
Significantly, yes, and this is really important for their use in toxicity. Quaternary carbamates like neostigmine are poorly absorbed from the gut, and importantly, because they are charged, do not easily enter the CNS.
Stays in the periphery.
Mostly. Physostigmine and the Alzheimer's drug rivastigmine, being tertiary amines, uncharged at physiological pH, are well absorbed orally and do readily enter the CNS, which is necessary for their effects, but also makes them potentially more toxic due to central side effects. Donepezil, another key Alzheimer's drug, is also well absorbed orally, metabolized by liver enzymes, and excreted by the kidneys, offering a convenient long half-life.
The organophosphates sound particularly dangerous, especially since you mentioned sarin and pesticides.
Yeah, are extremely dangerous. Most organophosphates are highly lipid-soluble, meaning they can easily cross fatty membranes and are readily absorbed from the skin, lungs, gut, and even the conjunctiva of the eye, making them hazardous via multiple routes of exposure and highly effective as insecticides.
Even through the skin.
Yes, skin contact can be a major route of poisoning for agricultural workers, for example. Thiophosphate insecticides like parathion and malathion are actually prodrugs. They are relatively inactive themselves, but are converted to their active phosphate derivatives, auxons, in animals and plants.
Activated in the body.
Right. Malathion is generally safer for mammals and birds because they possess enzymes, specifically carboxylases, that rapidly detoxify it, unlike insects or fish. Parathion, however, is not effectively detoxified this way in vertebrates, making it considerably more dangerous and a more common cause of severe human poisoning. And critically, almost all organophosphates, with the exception of the highly polar ecothiopate, distribute readily to the CNS. So central nervous system toxicity is a major, often life-threatening concern in poisoning.
And how do these indirect acting drugs, the cholinesterase inhibitors, affect the organ systems, especially since they're just amplifying the body's own acetylcholine? Are the effects identical to the direct agonists?
Since their primary action is simply to amplify endogenous acetylcholine, their effects are generally similar to direct-acting cholinomimetics, mimicking increased parasympathetic activity. But the magnitude and specific profile can differ, and they also affect nicotinic sites like ganglia and the neuromuscular junction more prominently than many therapeutic muscarinic agonists. In the CNS, as we just touched on, low concentrations from inhibitors that cross the blood-brain barrier can cause diffuse activation, maybe some alertness. But as concentrations rise, they can lead to cognitive disturbances, then generalized convulsions followed by coma, and ultimately respiratory arrest due to central respiratory depression and neuromuscular blockade.
A very dangerous progression.
Extremely. For the eye, respiratory, GI, and urinary tracts, effects are qualitatively quite similar to what we discussed with direct-acting muscarinic agonists. Meiosis, accommodation spasm, bronchial constriction, increased GI motility and secretions, increased urination. Again, this connects directly back to JM symptoms, the tearing, blurred vision, chest tightness. The cardiovascular system effects are complex but predominantly parasympathetic, mimicking intense vagal nerve activation. Pronounced bradycardia, decreased AV nodal conduction, and reduced atrial contractility, ultimately leading to a potential fall in cardiac output. This seems due to both amplifying acetylcholine at the heart and possibly effects at sympathetic ganglia or prejunctional terminals, inhibiting norepinephrine release. Cholinesterase inhibitors have minimal direct effects on vascular smooth muscle itself, as most vascular beds largely lack cholinergic innervation. However, at moderate doses, they can paradoxically increase systemic vascular resistance and blood pressure, perhaps initiated at sympathetic ganglia or central sympathetic centers overriding the bradycardia. High toxic doses, however, invariably lead to marked bradycardia and significant hypotension. This complexity is important for patients with underlying cardiovascular issues like hypertension, who might be taking these drugs for other conditions, like Alzheimer's. Careful monitoring is key.
Right.
At the neuromuscular junction, this is a crucial area, both therapeutically and toxicologically. Therapeutic concentrations prolong and intensify acetylcholine's action, which significantly increases muscle strength. This is vital in treating conditions like myasthenia gravis.
The key benefit there.
Exactly. But at higher concentrations, excessive acetylcholine accumulation can cause depolarization, leading initially to repetitive firing, seen as muscle fiber fibrillation. Individual fiber twitches not visible, and fasciculations, visible muscle twitches under the skin. With marked inhibition, you get that persistent depolarization leading to neuromuscular blockade and flaccid paralysis, including the respiratory muscles. Interestingly, some quaternary carbamates like neostigmine and pyridostigmine also have that modest direct nicotinic agonist effect at the NMJ, which specifically contributes to their effectiveness in treating myasthenia.
This leads us directly to the clinical uses. We've touched on some, but how are these powerful drugs actually used in medicine to treat patients?
Their major therapeutic uses really cluster in diseases of the eye, the gastrointestinal and urinary tracts, and the neuromuscular junction, as well as in managing symptoms of Alzheimer's disease. In the eye, for conditions like glaucoma, particularly open-angle glaucoma, muscarinic stimulants like pilocarpine and cholinesterase inhibitors like physostigmine ecothiopate were historically important for reducing intraocular pressure by contracting the ciliary body and facilitating aqueous humor outflow.
So they're less used now.
Yes, newer drugs like prostaglandin derivatives and topical receptor antagonists are generally preferred now for chronic glaucoma due to better side effect profiles. However, in acute angle closure glaucoma, which is a medical emergency where pressure rises rapidly, these cholinergic drugs, especially pilocarpine, are often used initially to constrict the pupil and pull the iris away from the outflow tract, buying time before definitive treatment like laser iridotomy. They are also sometimes used for accommodative esotropia, a type of crossed eyes in children related to focusing effort.
Okay, what about the gastrointestinal and urinary tracts?
For conditions like postoperative ileus, which is paralysis of the bowel after surgery, or neurogenic bladder, where the bladder doesn't empty properly due to nerve damage, bethanical, a direct muscarinic agonist, and neostigmine, a cholinesterase inhibitor, can be used to stimulate smooth muscle activity and promote emptying.
To get things moving again.
Exactly. But a critical point here for clinicians, they must always rule out a physical mechanical obstruction before using these drugs. If there's a blockage, stimulating contractions could cause severe complications like perforation.
A very important precaution.
Absolutely vital. Also, pilocarpine and a newer, more M3 selective agonist called cefimline are used to increase salivary secretion for debilitating dry mouth xerostomia, seen in Sjögren's syndrome, or resulting from radiation damage to the salivary glands after head and neck cancer treatment.
Right, for symptom relief.
Yeah.
Now, the neuromuscular junction. This sounds like a major application, especially for myasthenia gravis.
It is a particularly important application, yes. Myasthenia gravis, as we've mentioned, is a debilitating autoimmune disease where the patient's own antibodies target nicotinic acetylcholine receptors at the neuromuscular junction, drastically reducing their number and function.
So the signal from nerve to muscle is weakened.
Precisely. This causes the hallmark symptoms like ptosis drooping eyelids, diplopia double vision difficulty speaking, dysarthria and swallowing dysphagia, and generalized muscle weakness that worsens with exertion. In severe cases, it can affect respiration, which can be life-threatening.
So cholinesterase inhibitors are key here for myasthenia gravis.
Absolutely. They are invaluable for symptomatic treatment. Pyridostigmine and neostigmine are the mainstays for long-term therapy. They increase the amount of acetylcholine available at the weakened junction, improving neuromuscular transmission. Doses have to be carefully titrated for each patient to optimize muscle strength while minimizing side effects.
And you mentioned edrophonium earlier for diagnosis.
Yes, edrophonium tensilon test has a very short action. Giving a small intravenous dose causes a rapid but brief improvement in muscle strength in most myasthenic patients, which can quickly help confirm the diagnosis in the right clinical context.
And how do clinicians distinguish between worsening myasthenia needing more drug and drug overdose needing less in these patients? Since both can cause muscle weakness, it sounds like a really difficult differential.
That's a critically important question, especially when a patient already on treatment presents with increasing weakness. It's called distinguishing between a myasthenic crisis, too little drug effect, and a cholinergic crisis, too much drug effect. In a controlled hospital setting, the edrophonium test can be used again carefully.
How does that help?
If a small dose of edrophonium improves the weakness, it indicates a myasthenic crisis. The patient is undertreated and needs more anticholinesterase medication or other therapies like immunosuppression. If the atrophonium worsens the weakness or produces no relief, and the patient also shows signs of muscarinic excess, like cramps, diarrhea, sweating, salivation.
Signs of too much acetylcholine effect.
Exactly. That suggests a cholinergic crisis from excessive drug, indicating the patient needs less medication and potentially respiratory support, a crucial diagnostic tool in that situation.
These inhibitors are also used to reverse neuromuscular blockade in surgery, right? After anesthesia.
Yes, precisely. Neostigmine and edrophonium are drugs of choice to reverse the paralysis caused by non-depolarizing neuromuscular relaxants, like rocuronium or vicuronium, which are often used during anesthesia to relax muscles for surgery. They essentially wake up the muscles by increasing acetylcholine at the junction, allowing for prompt recovery of spontaneous breathing and muscle function post-surgery. They're usually given with an antimuscarinic like atropine or glycopyrrolate to block the unwanted muscarinic side effects.
What about Lambert-Eaton myasthenic syndrome, LEMS? Is that similar to myasthenia gravis? How are these drugs involved there?
LEMS is another autoimmune condition affecting the neuromuscular junction, but the underlying problem is different. Here, antibodies interfere with voltage-gated calcium channels on the presynaptic nerve terminal.
So the problem is releasing acetylcholine, not responding to it.
Exactly. This reduces the amount of acetylcholine released into the synaptic cleft when the nerve fires. While cholinesterase inhibitors might provide some modest benefit, the primary treatment involves drugs like amifampridine, 3,4,4-diminopyridine, which are potassium channel antagonists. They work by prolonging the action potential duration in the nerve terminal, which allows more calcium to enter and thus boosts acetylcholine release, thereby improving muscle strength.
Our source also mentions a few other, perhaps less common, uses for these drugs.
Yes, a couple of others. Edrophonium was once used occasionally to terminate certain supraventricular tachyarrhythmias, or rapid heartbeats originating above the ventricles, by increasing vagal tone to the heart. But it has been largely replaced by newer, more effective and specific drugs like adenosine and calcium channel blockers. And physostigmine, because it can cross into the CNS, can sometimes be used cautiously as an antidote to reverse severe central and peripheral signs of antimuscarinic drug intoxication, like a serious atropine overdose. However, its own potential CNS toxicity limits its use to only dangerous situations where reversing central anticholinergic effects is truly necessary.
And finally, Alzheimer's disease.
Right. For mild to moderate Alzheimer's disease, several centrally acting uncharged acetylcholinesterase inhibitors like donepezil, galantamine, and rivastigmine are approved. The rationale is that boosting cholinergic function in the brain might help compensate for the loss of cholinergic neurons seen in the disease.
Do they work well?
They can provide modest, temporary improvement in cognitive function or slow the decline for some patients, but unfortunately their clinical benefit is often marginal, and they absolutely do not stop the underlying progression of the disease. Donepezil is often favored for its once-daily dosing due to a long half-life and relatively better side effect profile, including less liver toxicity compared to the older drug tacrinet, which is rarely used now.
Given their powerful and widespread effects, what are the toxicities we need to be aware of? It seems like a very thin line between therapeutic use and dangerous overdosers for many of these agents.
You're absolutely right. The therapeutic index for many of these drugs is narrow, and toxicity is a major concern. The toxic potential varies greatly depending on the specific agent, its absorption, ability to access the CNS, and how it's metabolized. For direct-acting muscarinic stimulants like pilocarpine, bifanical, an overdose leads to predictable signs of excessive muscarinic stimulation. Nausea, vomiting, diarrhea, abdominal cramps, urinary urgency, profuse salivation and sweating, cutaneous vasodilation, flushing, and bronchial constriction causing wheezing or shortness of breath.
Basically, the parasympathetic system on overdrive.
Exactly, an exaggerated rest and digest response. Fortunately, these effects are competitively blocked by atropine, which is the specific antidote. Ingesting certain mushrooms, particularly those of the Inocybe genus which contain muscarine, can cause these exact symptoms, and they are typically treated successfully with atropine.
Okay, what about direct-acting nicotinic stimulants like nicotine itself?
Acute nicotine toxicity is extremely serious and potentially fatal. The fatal dose for an adult is estimated to be around 40-60 milligrams, or about one single drop of the pure liquid. That's the amount you might find in 2 regular cigarettes, although thankfully much is lost in smoking or absorption is slowed by vomiting if ingested.
That's a tiny amount for a fatal dose.
It is frighteningly small. The most dangerous effects involve the CNS and the cardiovascular and neuromuscular systems. Central stimulant actions can cause tremors, convulsions, followed by coma, and ultimately respiratory arrest. At the skeletal muscle end plate, initial stimulation is followed by that depolarizing blockade, leading to respiratory paralysis. And cardiovascularly, you can see hypertension, cardiac arrhythmias, potentially leading to cardiovascular collapse.
How is acute nicotine poisoning typically treated, given how rapidly it can progress?
Prompt treatment is critical and primarily symptom-directed, as there's no specific antidote like atropine for muscarinic effects. Management involves giving atropine to counteract any accompanying muscarinic excess, parenteral anticonvulsants like diazepam for seizures, and aggressive respiratory support, often including mechanical ventilation, for the neuromuscular blockade and central respiratory depression. Thankfully, nicotine is metabolized and excreted relatively rapidly, so patients who survive the first few hours with good supportive care generally recover fully.
And the chronic effects of nicotine. This raises an important question for all of us, given its prevalence in tobacco products.
Indeed, chronic nicotine toxicity, primarily from tobacco smoking, is the largest single preventable cause of illness and premature death in the developed world. Nicotine itself, beyond the other toxins in smoke, likely contributes significantly to an increased risk of vascular disease, potentially triggering endothelial dysfunction, increased platelet aggregation, and altered lipid profiles. It's also linked to sudden coronary death and impaired healing or recurrence of peptic ulcers.
What about e-cigarettes or vaping?
Electronic cigarettes or vaping still deliver nicotine, often in high concentrations and in ways that might be even more addictive due to rapid absorption. While potentially less harmful than combustible tobacco in some respects, they are certainly not harmless. And there have been very concerning reports of acute lung injuries, EVALE, and even deaths linked to vaping, particularly products containing THC and additives like vitamin E acetate, though the long-term effects of inhaling the flavorings and vehicle components are still largely unknown.
What about efforts to help people quit smoking, which is such a huge public health challenge? Do these involve manipulating the nicotinic system?
Yes, several strategies target the nicotinic system. Nicotine replacement therapy, NRT, available as gum, patches, lozenges, nasal spray, or inhalers, works by providing a slower, lower dose of nicotine to occupy those critical alpha-2 receptors in the CNS. This helps reduce craving and withdrawal symptoms without delivering the rapid peak and toxic components of cigarette smoke.
So, satisfying the receptor partially.
Right. Varenicline Chantix is often a more effective pharmacotherapy. It's a synthetic drug specifically designed to act as a partial agonist and antagonist at those afutinitinic receptors. This means it both partially stimulates them, like nicotine, to reduce craving and withdrawal, and it blocks nicotine from cigarettes from binding effectively, reducing the rewarding stimulant effect if the person does smoke.
A dual mechanism.
Yes. And bupropion, Zebin, an antidepressant, also aids smoking cessation, possibly through mechanisms involving non-competitive antagonism of nicotinic receptors and effects on dopamine and norepinephrine pathways.
Our source also mentions neonicotinoids. What exactly are they, and why have they become so controversial, especially regarding bees?
Neonicotinoids are synthetic compounds structurally resembling nicotine, specifically developed as insecticides starting in the 1990s. They were designed to be more toxic to insects than vertebrates because they bind more strongly to insect nicotinic receptors. This selectivity led to their widespread agricultural use as systemic pesticides, meaning they're absorbed by the plant and distributed throughout its tissues.
Systemic, so the whole plant is protected.
Yes, which protects against pests, but also means the insecticide is present in pollen and nectar. There's significant scientific concern and evidence linking neonicotinoid use to declines in pollinator populations, particularly bee colony collapse disorder. They are suspected of impairing bee navigation, foraging, and suppressing their immunity against pathogens like mites, Varroa destructor, and fungal infections, Nosema.
That's serious.
Very serious. This led to bans or restrictions on their use in the European Union and some parts of the U.S. They pose a long-lasting hazard because they can persist in soil for a long time and continue to be taken up by subsequent crops or wildflowers, impacting pollinators over extended periods.
Finally, let's discuss the toxicities of cholinesterase inhibitors themselves, especially given their use as pesticides and even, terrifyingly, as chemical warfare nerve agents.
The acute toxic effects of cholinesterase inhibitors are direct and often devastating extensions of their pharmacological actions. They are most commonly seen in accidental or intentional pesticide exposure, especially organophosphates, or, as you mentioned, with the use of chemical warfare nerve agents like soman, sarin, VX.
What are the signs?
Initial signs are typically those of dramatic muscarinic excess. The acronym D dumbbells is sometimes used: diarrhea, urination, meiosis, pinpoint pupils, bronchospasm, bronchuria, wheezing fluid in airways, emesis, vomiting, lacrimation, tearing, salivation, sweating.
A very dramatic picture.
Extremely. And this rapidly progresses to severe CNS involvement, including confusion, ataxia, slurred speech, generalized convulsions, and coma, usually accompanied by peripheral nicotinic effects, starting with muscle fasciculations, followed by depolarizing neuromuscular blockade, leading to profound muscle weakness and paralysis, including the diaphragm and intercostal muscles, causing respiratory failure. This is precisely what JM in our opening case study was experiencing from likely organophosphate exposure.
How are these severe intoxications treated, particularly given their rapid progression and lethality?
Prompt recognition and aggressive, immediate treatment are absolutely critical for survival. Management involves three main principles. 1. Maintaining vital signs, especially respiration. This often requires immediate endotracheal intubation and mechanical ventilation. 2. Decontamination to prevent further absorption. This means removing all contaminated clothing immediately and thoroughly washing the skin with soap and water. Healthcare providers must wear protective gear. 3. Pharmacologic therapy. Large parenteral doses of atropine are given repeatedly to block the life-threatening muscarinic effects, especially the bronchuria and bronchospasm. Atropine does not reverse the neuromuscular paralysis. For that, prelidoxin PAM, which is a cholinesterase reactivator, is often given, especially in organophosphate poisoning.
Prelidoxin reactivates the enzyme.
Yes. PAM works by pulling the phosphate group off the serine residue in the enzyme's active site, thereby regenerating functional enzyme. However, it's crucial that PAM is given before that aging process occurs, which makes the bond permanent. So early administration is key. It's generally less effective for carbamate poisoning. Benzodiazepines like diazepam are also used to control seizures.
And there's even preventative therapy for potential chemical warfare agent exposure for soldiers, for example.
Yes, military personnel and sometimes first responders expected to operate in contaminated environments may be given pre-treatment with pyridostigmine, a carbamate inhibitor.
How does that help against something like sarin?
Pyridostigmine, being a reversible carbamate inhibitor, temporarily binds to a fraction of the acetylcholinesterase enzyme. This protects that fraction of the enzyme from being irreversibly phosphorylated by the organophosphate nerve agent. When the pyridostigmine wears off in a few hours, that protected enzyme becomes functional again while the body clears the nerve agent. It's usually given in combination with autoinjectors containing atropine and PAM for immediate use upon exposure.
Is there chronic toxicity from these agents too, or is it mostly the acute crisis?
There can be chronic or delayed effects, unfortunately. Chronic low-level exposure to certain organophosphates can cause neurological and cognitive deficits. More distinct is a delayed neuropathy called organophosphate-induced delayed neuropathy, OPIDN, which involves demyelination of sensory and motor axons, appearing weeks after an acute exposure.
Weeks later?
Yes, and importantly, this is not due to cholinesterase inhibition, but rather the inhibition of a different enzyme called neuropathy target esterase, or NTE. There's also something called the intermediate syndrome, which involves muscle weakness, particularly of neck flexors, proximal limbs, and respiratory muscles, appearing 1 to 4 days after apparent recovery from an acute cholinergic crisis. Its precise origin is unknown, but seems related to prolonged cholinesterase inhibition at the neuromuscular junction.
What an incredible and somewhat daunting journey into the intricate world of Cholinoceptor-Activating and Cholinesterase-Inhibiting drugs. We've navigated everything from their historical discovery and incredibly detailed molecular structures to their profound and often surprising effects on nearly every organ system, and their critical roles in both therapy and toxicology.
If we connect this to the bigger picture, it's really clear how truly mastering this information, like the elite professionals in this field, gives you the insight to understand the underlying mechanisms of so much physiology, everything from vision to digestion, muscle movement, even cognitive function and addiction. The precision with which these compounds act, or are inhibited, really highlights the exquisite, often delicate balance within our own bodies and the astonishing complexity of biology at the molecular level.
So what does this all mean for you, our listener? You now have, hopefully, a much deeper appreciation for the double-edged sword these molecules represent. The same fundamental principles involving acetylcholine signaling that can be harnessed to treat a devastating disease like myasthenia gravis or help manage Alzheimer's symptoms can also be exploited as potent insecticides or even horrific chemical warfare agents.
It really underscores the responsibility that comes with understanding these powerful biological mechanisms.
It truly makes you think about the delicate interplay of chemistry and biology that governs life itself, and how profound our impact can be when we understand these systems at their deepest level. We hope this deep dive has given you a newfound mastery of this complex yet utterly fascinating topic.
Yeah, there's a lot there, but hopefully connecting the molecules to the effects makes it clear.
Until next time, keep exploring, keep questioning, and keep diving deep.